you. Good afternoon. I thank the organizing committee. I thank my colleagues who are moderators. And this is the first time I come to Zahra Hospital, but I can honestly tell you that if we have a patient and if we cannot accommodate this patient at the Children Cancer Center, the first thing that I say and many others say, let us send to Zahra Hospital. And this has nothing to do with being friends with Dr. Nadas Beiti. This has to do with getting the best treatment for the patient. So I have repeatedly said that if you want this patient to be cured, then and get a treatment which is equal, if not sometimes better, let us send to Zahra Hospital. And I can tell you that my friends here will take excellent care of the patient. And this is a truth. This is the first time I come here, but I thought it was my duty to say so because this is what happens. If we want our patient to be examined every time, if you want the details to be taken care of, this is the place where I personally, and now most of my colleagues do, they send our patient to the place where the patient has the most chance to survive. And I am only telling the truth. If I was not here, probably you would not have heard this except at AUB, but this is what usually happens.
Thank you, doctor.
So what I will be talking about today is GI lymphoma. And GI lymphoma, in contrast to what Dr. Ael discussed, is not a very surgical disease. So although the early stages of Burkitt lymphoma may be complete removal of the disease, we do not like that. This is a disease that melts with chemotherapy, and we would like the minimum surgery to be performed on these patients simply because chemotherapy will take care of them. So malignant lymphomas are the third most common type of childhood cancer. And if you go to areas in Africa, they might be the first because EBV is endemic there. So in our countries that are midway between the Africa endemic Burkitt and the United States, we see a lot of childhood Burkitt lymphoma of the abdomen, and this is by virtue of our location in geography, and this is by virtue of our children having probably EBV at an early age. So they usually have different anatomic distribution, whereas the Burkitt African is usually of the jaw. Our Burkitt lymphoma is usually of the abdomen, and very similar to that in the Western and American countries. Now, children, how do they present? They typically present with diffuse extranodal disease in contrast to adults where they present with nodal disease. And non-Hodgkin lymphoma, Burkitt, and large B-cell lymphoma, which we treat the same, remain the most common malignancy of the GI tract in children. And we have seen very small tumors that were barely caught because of a small intussusception, and we had children coming like a 9 months old pregnant. So we see all variations of the disease. Peak age of non-Hodgkin lymphoma of the GI tract is 5 to 15 years. Survival is high, and if you use the aggressive protocol that the French, the LMB French started, you may be able to cure every patient except for those with CNS disease. And now, after the advent of rituximab, hopefully we will be hoping to treat even patients with CNS disease. Unlike adult patients, sorry. Unlike adult patients in whom the stomach is the most frequent site, small and large intestines are the most commonly involved sites in the pediatric age group. And when we looked at our patients over 10 years, almost all of them started at the ileocecal valve. So, what are the clinical presentations? Abdominal mass, acute abdominal emergency caused by intussusception or appendicitis. And any child who comes with intussusception, and this child is above the neonatal age, where the age that intussusception occurs, any older child who comes with intussusception, we need to think of Burkitt lymphoma. So you tell me, okay, anyway, we are going in to fix the intussusception. I tell you the trick here is to send to pathology. Any child above 1 year who comes with intussusception, the surgeon goes in to relieve the intussusception, please send for pathology, because the chances are that this is large B-cell lymphoma or Burkitt lymphoma. So the commonest presenting symptom is abdominal pain, abdominal swelling, distension, vomiting, palpable abdominal mass, alteration in bowel habits, and intestinal obstruction, with 3 lines under intestinal obstruction. Are there any other pediatric lymphomas of the GI tract, of the abdomen? And the answer is yes. We see Hodgkin lymphoma of the abdomen. And to tell you the truth, Hodgkin lymphoma usually does not start in the lower part of the body. It starts in the cervical, mediastinal, and then if we see a patient with cervical and mediastinal lymphoma, we look for Hodgkin's disease of the abdomen and the pelvis. However, every 10 years or 8 years, we see a patient having inguinal Hodgkin's disease, and this is starting at the inguinal area. It is not very common. The last patient I saw last week had diffuse large inguinal lymph nodes, but nothing in the upper part of the body. And we started thinking about GI problems, about GYN problems, and then it turned out to be Hodgkin's disease. So Hodgkin's disease starting in the lower lymph nodes of the body, of the abdomen, is not non-existent. It can exist, it is rare, we rarely see it, but it is there. Now, what are organs involved by pediatric Hodgkin's disease? And this is mostly مثل ما قلنا, starting at the cervical area or the mediastinal area, then to involve the spleen, liver, GI tract, pancreas, abdominal wall, GI tract, adrenal. But in all of these cases, we have a primary or starting at the cervical area. Please keep in mind that inguinal Hodgkin's disease going up to the abdomen also exists, and we need not to forget about that. So pediatric GI lymphoma has a wide distribution, including all sites, abdominal lymph nodes, regional lymph nodes, and mesenteric lymph nodes. Nearly 50% of children with GI lymphoma have tumor infiltrates confined to the GI with possible regional lymph nodes. So this is the American type of Burkitt lymphoma, the non-African type, where they have only the cervical lymphadenopathy that was first described by Burkitt's, and our type of Burkitt lymphoma and non-Hodgkin lymphoma is very similar to the American type, and they usually present with only abdominal disease. Subcutaneous nodules are rare in both large B-cell lymphoma and Burkitt lymphoma, and seeding of the skin and subcutaneous tissue is also rare. Satellite lesions and regional metastases are seen, but usually the disease is confined to the abdomen. Now, I will not go through the differential diagnosis of all causes of mediastinal masses in children, but I can say that as a group, we have the pelvic, which are 15% that include ovarian cyst, sacrococcygeal teratoma. We can have the intraperitoneal making out 20%. Of these, 15 are GI masses, duplication, meconium ileus, hepatobiliary masses, and 65% in the flank. All of these are the differential diagnosis of masses in the abdomen, but they don't need to be malignant. So our role is to do a biopsy, see, and to do the proper imaging, check what the tumor is it malignant, is it non-malignant, and go from there on. Differential diagnosis of malignant masses in children, neuroblastoma is the most common, solid tumor, Wilms, hepatoblastoma, germ cell tumors, and lymphoma. As for GI tract tumors, I need to tell you that what you see in adults, what you do surgery for in adults are completely and very rare in children. So although we see GI lymphoma, we see very little colorectal carcinoma, and we only see them in familial adenopatous polyposis. And to tell you the truth, we just send them to the adult people because they see more of them. So if somebody sees 100 cases, he will or she will be more capable to take care of these patients. GIST tumors, we see very few, and they are aggressive tumors. We treat them, and thank God they are rare because their treatment is not that good. Inflammatory pseudotumor and gastric tumors, adenocarcinomas are very rare. So thank God we deal with lymphomas, and lymphomas are curable. How do we diagnose them? GI tract tumors are rarely seen in children and adolescents and can be easily misdiagnosed. Ultrasound is the first imaging method, but we all know that ultrasound is not that exact. So CT and MRI should follow in clinically suspected cases. We rarely need to do colonoscopy, and because adenocarcinoma and the other diseases that you see in adults are very rare in children. Barium studies are not used nowadays, so we rarely, if ever, do barium studies these days. CT and MRI are necessary for local and distal extension of the tumor to the peritoneal cavity, retroperitoneal lymph nodes, and or metastases, and we can see calcifications. Now, I have an advice. If a child comes with intrasusception or if something is suspicious, please do imaging before taking the patient to surgery. And when you take the patient to surgery, send a pathology. Now, what's the first approach? Pathology confirmation. We can do it by non-surgical procedures. They can do it in X-ray department. They can take a small piece of the pediatric abdominal non-Hodgkin lymphoma, and we can do markers and diagnose that this is a Burkitt lymphoma or large B-cell lymphoma. And this has very low morbidity rate, and this allows an earlier resumption of full diet and makes us able to start chemo early. Furthermore, non-surgical procedures should also be considered for obtaining tumor samples from patients with extensive disease. If we're going in and we know we are probably talking about a lymphoma, not about a neuroblastoma, then no need to take a tissue biopsy, no need to open. We just need to take a core biopsy, do the markers on it, and start chemo as quickly as possible. The ideal approach to GI lymphoma remains controversial, and there is controversy between children and adults. Again, in adults, GI surgery is like more common, it is more accepted, and is usually used for localized disease. In pediatrics, the approach is different and varies among physicians. Sometimes you need to go and do the surgery. If there is intussusception, if the child is in severe pain, then you have to go in. You have to relieve the intussusception, and please take a biopsy when you do that. But if there is no obstruction, there is no intussusception, or the patient comes with a huge abdomen and this is full of lymph nodes, in intervention radiology can go in, take a biopsy. We can do the markers, both regular markers and molecular markers, and this will be less harm and less waiting on the child. Recent studies have proposed the use of chemotherapy alone as an effective treatment in GI lymphomas. So although everything in oncology is multidisciplinary, and we need the surgeon for each and every patient in oncology, probably lymphomas and leukemias are the two diseases that we need the surgeon least. And if we do the biopsy by intervention radiology, what remains is only to put the polycyte or portacath, and the lesson or the message that I would like to give you today is try to minimize surgery for patients with pediatric lymphomas. So lymphomas in children, especially Burkitt, grow very quickly. It is the fastest growing tumor. And sometimes they are very large. And I told you I saw a patient like a 9-month pregnant. Even children and teens with early stage 1 or 2 are assumed to have widespread disease. So if the surgeon goes and removes the complete area at the ileocecal valve with Burkitt lymphoma, do I have the courage to treat as per stage 1 the least aggressive protocol? And my answer is no, because this is a very rapidly growing tumor. This is a tumor where you have one shot at treating, so it is not like Hodgkin, where if I treat a patient with Hodgkin's disease and then he recurs or she recurs, then I have a 95% chance of cure. No, this is a disease where I have one chance of cure. If I do not hit Burkitt lymphoma very quickly and within very short periods of time between each chemo, and if this patient recurs, this patient will be dead. So we have to keep in mind that Burkitt lymphoma has a very high turnover rate. If we do not treat quickly, aggressively, make the chemo close to each other, we will lose the patient. So chemotherapy is an important part of treatment of all Burkitt and non-Hodgkin lymphomas. Now, what is new? The new thing that came is immunotherapy, CD20, anti-CD20, rituximab. We used to lose more patients before rituximab. Rituximab now enters the CSF and can make us take care better of patients with CNS disease. We are happy that it is here, and we treat now almost every patient with rituximab. Radiotherapy, rarely. We should probably never use in a straightforward case, and surgery, the least invasive, the better. Again, if you have an intussusception in an older child, then the surgeon has to come first, take a pathology first, and then comes our role. Conclusion, GI tract tumors are rarely seen in children as you see them in adults. So if you take the differential in adults, what you see in adults, you cannot extrapolate this to children. Different and broad histopathologic spectrum. Awareness of early diagnosis is very important. If you wait on the Burkitt lymphoma, it will go to the brain, it will go to the bone marrow, it will be less treatable. We strongly imply that despite a normal ultrasound examination, don't be satisfied with an ultrasound examination. Do CT and MRI where you suspect a diagnosis or the possibility of Burkitt or non-Hodgkin lymphoma of the abdomen. Management options are variable, and each institution and even each pediatrician and oncologist does what he is more relaxed to do. So even if you send me a patient and this patient has completely removed disease, I will not treat as stage 1. You tell me, but the book does not say that. I tell you, you treat like the book says. If this patient fails, if Burkitt lymphoma recurs, the patient is dead. The major role is for chemotherapy and immunotherapy, now with rituximab, anti-CD20, and for the surgeon, the less invasive approach for diagnosis is always the preferable approach. Thank you.